Okay, so I'm doing a bit of psychiatry today, bit of prescribing, and then there'll be like a random picture quiz at the end. Sorry that things kind of got away with me this week, so it was a bit more like last minute than planned, but we'll kind of get cracking a bit. So a 64-year-old gentleman presents with anhedonia and low mood following the death of his wife 4 months ago. He has a past medical history of a MI, peripheral vascular disease, hip osteoarthritis, and gorge. Please prescribe a suitable medication for him and rationalize his drug chart given the addition. So there are like multiple right answers for this, so don't worry. And the thing with OSCEs is there's also multiple right answers for things. Like they often, there'll be a few drugs in a class which will be reasonable for that situation. And we kind of had a station similar to this where you had to look at their drug chart and kind of rationalize or pick up on any errors, basically. I'd say all the doses are completely normal, so don't feel like you have to whip out your BNF and check my dosages. They're all like standard ones. So I will give you guys a few minutes just to like get up your BNFs on your phone and just have a look and just pop in the chat what you would what you would give this person. And it's sometimes a bit of like a rock and a hard place. Like a medication can be really good for one thing, but not so good for another thing. So if you can justify it, like it's probably reasonable given the balance of like risk and benefit. Oh, and if anyone hears any purring during this, it's because there is like a cat next to me. It's not like some weird background noise. So sorry if Wilson like purrs too much. Okay, does anyone throw me a class or a drug that they probably want to give this gentleman? Yeah, so sertraline's a good shout. That's kind of the go-to given this history that's very much like sounds like a depression basically because of the death of their wife and the anhedonia and low mood. And yeah, keeping the omeprazole is good. So what in the history makes sertraline like quite a good shout as a choice of SSRI? So it's not, so maybe with like the oh yeah, so CBD, sorry, I thought you said PVD. So yeah, the history of MI, so it's really good in that. And then what are the things that we worry about with giving SSRIs, which like given this gentleman's medications? Jess, you kind of touched on it. So yeah, ulcers and the sort of main big thing that ulcers would kind of cause. Unless that's what like UGIB stands for, which like if it's ulcer related bleeding, that's the thing that we're worried about. And so for me, sertraline has been found to be the best for people who've had a history of MI, but then also if you've had an MI, you get put on the aspirin, the clopidogrel, that kind of stuff. Oh, upper GIB, cool. And so it's a bit of a balance really, but that's a really good shout. And then there's basically one drug that you would kind of avoid for this gentleman, and that would be the naproxen that he's on. So that would basically be it. And then your other option, which would have been completely valid, is also like citalopram. So if you were being kind of bleed averse, then you'd go for that. So if they'd had a history of like brain hemorrhage or anything like that, or severe ulcer disease, you might pick that first. And then the main thing with citalopram is just to check if they've got long QT first, whereas you wouldn't necessarily have to do that with sertraline. You could kind of get away with starting it. Cool. Which possible, so for some reason, every time people join, all of my animations go. So 1 second, and then they kind of reverse. So this is pointless. So you guys probably saw all of those. So give me 1 second. I'll just, if I realign everything, I will be able to remember what I was going to ask. So the main side effects with starting an SSRI is, we've already talked about, is bleeding. The mood worsening in the initial few weeks is quite a key thing. So often the GPs will bring them back, you know, like a week later or 2 weeks later, and you'd warn them about increased suicidal thoughts and that kind of stuff. And then sexual dysfunction is quite a big one. So it is something like worth counseling patients on and making them aware of it, that they can have issues with like libido as well and sexual function. And then it can affect their sleep, and it can make them weirdly more anxious. So that's something to bear in mind. Okay, right, this one I don't need an animation for. So, which SSRI is contraindicated in the first trimester of pregnancy and why? And then that's your list. So they like love all these like prescribing and pregnancy things in 5th year. So so one person's gone for D. What does everyone else think? Agree, disagree? D rings a bell. Any of the rest of this, any of the 7 remaining want to wade in? Okay, well, your 2 colleagues are right. So well done. So yeah, it's the big one is paroxetine. That is the one that you avoid because it does have this increased risk of cardiac defects. The others are all kind of, you can use them under a kind of risk-benefit ratio. And the only thing to remember is like sertraline in the 3rd trimester can cause this persistent pulmonary hypertension of the newborn. But apart from that, it's pretty okay. Okay, so right, so I did a few likely side effects of drugs. So let me just write them in the chat because with my things. So if anyone wants to pop the most likely side effects for the following drugs, and then we can go through them. And sorry that my things have failed me once again. And so let's go for any side effects of them. It can be a side effect, the most common. Let's see what we get. Because antipsychotics and the antidepressants are pretty big. So yeah, olanzapine. So yep. So with the antipsychotics, it can put you at greater risk of like diabetes, metabolic syndrome. And yep, clozapine, so worry about agranulocytosis. So there's special clozapine clinics where they check with an FBC and watch that if the white cell count goes down, if they get any kind of illness, signs of infective illness that you worry. Haloperidol, so yep, extrapyramidal side effects, that's good. And then, yeah, there's like a few other things with clozapine as well. So the hypersalivation is actually the most common side effect. And they give hyoscine butyl bromide, so like one of the anti-secretions to kind of cover that if the patient's affected. Okay, cool. So we'll go through these. So these are the kind of most common ones for them. And I think in SBA land, it is worth knowing like what the most common side effects are of some of these. But I think for most things, it will be quite standard. So for your like olanzapine, it's weight gain, and that can be quite beneficial if someone's already underweight. So if they're like an elderly patient or like a dementia patient who's not eating, that can be quite helpful. Hypersalivation for clozapine, as I've said, haloperidol, it's long QT, and quetiapine, it's low hypothyroid. And yeah, so I think for clozapine, there's also a reduced seizure threshold, and for a few of them, so it can be a bit of a balancing act if you've got someone with depression or psychosis who's epileptic. Cool. So a bit more prescribing. So this is my terrible excuse for drug chart. So you are a psychiatry F1 and you've been called to review a female patient today who's been diagnosed with acute mania. Over the phone, you are given the current medications to review prior to seeing the patient. So this is SBA land where you know nothing about the patient other than their medications. So which medication will you add given the new diagnosis? And like you can give me a group of meds, I don't mind. And then also, what are you going to amend on this drug chart? And so this is kind of just showing that like all of these drugs have been given for the last few days, and then this is today's date. So which ones are you going to keep giving? Which ones might you stop? Which ones are you absolutely going to stop? And some like you might just hold it for a bit and check something. Ooh, so stop fluoxetine. I think you need to stop the antidepressant in mania. So that's correct. So if you think about it, an antidepressant is making someone's mood go up. Their mood is already like sky high. So you're going to want to like hold that for a bit or taper it. And obviously you do that with some senior help as well. And then, yeah, we're moving to like antipsychotic therapy just to bring them down in the acute phase. So you could use like an atypical antipsychotic first, because those have kind of the better side effect profile initially. Is there anything on that drug chart that might worry you? Or like a combination of things? So yeah, fantastic. So Navitha, you picked up that they're on sumatriptan, which is contraindicated with fluoxetine because you've got an SSRI with a 5-HT as well. So you're going to want to stop the sumatriptan. Does anyone know why they might be on the sumatriptan and the propranolol? What's like the most likely thing this patient also suffers from? So yeah, migraine, those are like the classic two. So you would probably, I mean, even though you're stopping the fluoxetine, you'd probably stop the sumatriptan just to make sure it's not given, and just see if they, you'd rather they get a migraine than get serotonin syndrome. And that could be a cause of their acute, that could be compounding. You haven't gone to see the patient just yet. And then, yeah, the ibuprofen, as we've talked about previously, if you're on an SSRI, you could think about, should they be on ibuprofen or could they be on like paracetamol or something? What is it actually for? Are they actually in pain? So like all of those things really. So this is my kind of crazy way to write it. So I think also given the fact that they're in a mania, it's always good to just check the lithium level. You don't know if this patient's actually been taking their lithium, if they've been taking too much lithium, if it's like a sub-therapeutic dose. So that would be worth doing that. And then whenever you're like altering the chart, make sure you cross it off, initial, sign it, and give your bleep number. And then, yeah, so we've gone through, I think, all of the points. And yeah, all of this is obviously going to be under like, under some supervision from other people. So if we talk about their lithium, so it might not be in this case, but if we talk about lithium toxicity, what's the main precipitant or some examples of precipitants for the lithium toxicity? So yeah, dehydration, AKI. So generally, it's all under this kind of broad premise of like anything that it's renally excreted, so anything that drops the renal function will cause the lithium levels to rise. And then you can also throw in overdose there. I mean, a lot of patients are monitored for like how they take the medication, but I guess it could also be intentional, like unintentional overdose. Does anyone know how lithium toxicity presents? What a patient might come in with symptoms-wise, or might you might find on examination? Yeah, so Anoja, you've come to kind of my general, like I think it's quite an easy way to remember and pick up if it's lithium toxicity. So it's quite cerebellar in nature. So yeah, they get an ataxia. What other kind of cerebellar features might they get? So yeah, nystagmus and tremor as well. And I'll come on to the tremor in a second. But otherwise, like with other symptoms, so they'll get probably confusion, they might get slurring of their speech. Cardiac wise, it slows everything down. So I like to think of it as like it just slows them down. So it makes them confused and slows their movements as well. And with the ataxia and then bradycardia, renally, it can cause an interstitial nephritis, which then makes the kidney function worse. So again, it's just kind of a self-fulfilling prophecy. And then there's a few hematological things. There's diarrhea and vomiting, the kind of standard. And then a kind of classic question that can kind of come up is like which medication to, which test to do in patients on lithium. And like the main one is that it's very common for it to cause thyroid problems, hypothyroid being the problem. So that one's also worth noting. And then it's very common for weight gain to happen, especially in women. And so it can be a very difficult drug for patients to be on because it can increase their risk of getting diabetes and high blood pressure, and can obviously affect their self-esteem. So yeah, touching on the kind of general, I think sometimes it's quite difficult to discern between a neuroleptic malignant syndrome and a serotonin syndrome and a kind of lithium toxicity. But I'd say if you were just thinking very simply, so lithium has a lot of these cerebellar features, which the others don't have. And then when you're distinguishing between neuroleptic and serotonin is faster. They get hypertonia, hyperreflexia, and they get eye signs. They get a very sympathetic drive to it. Whereas in NMS, they don't really get that sympathetic as much. Their eyes will be, their pupils will be normal. They'll have like this gradual onset lead pipe rigidity, but they won't have this kind of like the mydriasis and that kind of stuff and the clonus. So I think sometimes it's easier to think about how they're different rather than the symptoms that are similar, because there's quite a big overlap between the two. Okay, cool. So with lithium in pregnancy, what do we worry about? Do we give it? Do we not give it? Boom, Jess is in there. So what is Epstein's anomaly? Simply, because I'm now a post-finals simple girl who will probably know less about this than you. Do you remember like what kind of thing it affects or where it affects? So yeah, it's of the tricuspid valve. So let's have a look. So this is our, interesting, my animation seems to have returned. Weird. Okay, so this is our echo, and don't worry, they're not going to show you an echo, but sometimes it just helps. So you can see that the mitral valve is sitting where it should be, and you've got the nice big left ventricle, but the tricuspid valve is displaced downwards, causing a very small right ventricle, and so that's what Epstein's anomaly is. So Just have that basically in the back of your mind. Why lithium causes it, I don't know. In that it's probably quite an interesting reason, but we don't really know how lithium works completely. So I wonder if we'll never know. Okay, so we know that lithium causes a tremor and toxicity causes a tremor as well. How might we, given the fact that the previous picture of the other symptoms of toxicity, how do we think the tremor will be for lithium toxicity? And you can tell that I've been at Queen Square too long. But just simply. So is it coarse or is it fine? What do we reckon? So yep, it's a coarse tremor. It's got that cerebellar tremor that's very coarse. As it's a drug that's caused it, do we think it's going to be asymmetric or symmetrical? So yeah, it's going to be a bit more symmetrical, and so it's coarse, it's widespread, and the main thing is that you can get this, and it can be a reason that patients stop lithium. You get a tremor, a bilateral tremor at therapeutic doses, but it's a lot finer. But so tremor isn't exclusive to toxicity, but if they've got a coarse tremor that's widespread, then you're thinking about toxicity. The tremor can also not just be of their hands, it can be of their head, which can be quite disabling for patients as well. On the slides, which I'll upload later, if you go on YouTube, you can see what this looks like with patients, and I think it can be quite useful to see clips of what these things look like. So lithium is one of the drugs that has a very narrow therapeutic range, so we monitor it. And I think you guys are going to know what question I'm going to ask, but so we do digoxin levels, we do INRs for warfarin. When do we measure the lithium trough dosage? Yeah, fantastic. So 12 hours after the dose. Great, cool. So I've talked a little bit about ataxia due to lithium. What would be our other, because this will come up I think a bit in Jerry's, and there's a few kind of main things to know for fifth year. It's obviously a bit more finalsy, but let's just divulge a second. So broad groups of things that cause ataxia, throw them out there. Let's go for it. So yeah, the big one is alcohol, and that's your most common for adults presenting. And yep, Jess has gone for my favorite. So genetic, such as Friedreich's ataxia. Yep, so vascular, such as stroke to the cerebellum. And the brainstem as well. So yep, SOL. Sorry, I don't know what you mean because I'm quite bad at acronyms. What does SOL mean? It's probably right. I just don't know what it is. Space occupying lesion. Oh yeah, obviously. Yeah, that is one. Cool. And yeah, I've seen someone with a space occupying lesion that presented with ataxia. So the other ones, general, always can say it's infective, drugs, which we've said, MS, so that kind of comes under the autoimmune, para-infectious, weird middle zone, vascular, malignancy, and genetic. So we'll just kind of briefly touch on some of them. So generally, when you see a patient with ataxia, you're kind of thinking, is this alcohol? Is this vascular, or something really bad, or is this genetic? And when you see a very young patient, you're thinking about taking a good drug and alcohol history. You're thinking about if they've had an infection, or you're thinking genetic. That's kind of your route. And I'd say this isn't exhaustive, but I think the main ones just to take away is alcohol. So that can either be acute intoxication, which I'm sure everyone has seen or perhaps experienced. And And then Wernicke's and cephalopathy, so have they got an ophthalmoplegia and confusion alongside. Infective, so just anything, there's loads of viruses, loads of bacteria, I didn't really list them all. But also if you've got anything affecting your vestibular system as well, that can make you ataxic if you're not able to balance properly. And then there's a few drugs as well. Generally, it's all the kind of classic sort of nasty old school ones. So I think if you're ever unsure, like phenytoin is always a shout. And then, yep, MS, there'll be a few others, like Guillain-Barré might do it. Anything that causes a sensory disturbance might also do it. But then the main one with vascular is you're thinking like a cerebellar or like a posterior circulation stroke, so vertebrae basilar system. And then malignancy, so space-occupying lesion, or something kind of paraneoplastic and weird, but like, again, I spent too long at Queen Square, so I would just park that. And then the genetic ones, so the most common is Friedreich's ataxia, so like that would be the go-to. Does anyone know like what a Friedreich's patient might also have? Or how it's inherited? So it's not autosomal dominant. So autosomal dominant, I like to think of it's mostly the very structural diseases such as like Marfan's, or it's the kind of cancer causing ones. So like all of the kind of gynae cancer ones like BRCA and Lynch and von Hippel-Lindau, that kind of thing. They're all quite autosomal dominant related. And I think if you're not sure, think about it like that. And then Friedrich's, what would be your kind of second option? So yeah, the kind of stretch question is it is a trinucleotide repeat disorder. So that's the same with like Huntington's as well, and the spinocerebellar ataxias do that. You don't really need to know, but I think for Friedrich's and Huntington's, know that they're like these trinucleotide repeats. So those increase with the generations that keep going. So you're going to get earlier onset of the disorder and like, or possibly like a more severe manifestation of it. So with Friedrich's, it's autosomal recessive inheritance. So they can also have, it's that one of those, they get scoliosis as well, is like the main thing that they get. And they get difficulty. So they get difficulty with motor tasks, and then it progresses to like difficulty with speech and swallowing, and they get cardiomyopathy as well, which is the main cause of death. And then Wilson's is obviously our copper disorder. Charcot-Marie-Tooth is so it's a sensory ataxia, so they get the pes cavus, and the champagne bottle legs, that kind of thing, with the distal wasting. But again, like I don't think you need to know that for fifth year. Spinocerebellar ataxias, like there's legit loads of them, but like you won't need to know that for that one either. And then yeah, a few of the weird and wonderful things, but yeah, sorry, it's like my area of passion, so I will move on before I don't stop talking. So going a bit sort of Jerry's focus. So a 78-year-old man presents off his legs with urinary incontinence. A CT scan is done. What would be the most likely finding on LP? And that's like follow up with the most likely diagnosis. So we've got a vote for D. I guess like it kind of says, okay, so we've got a C as well. So we've got a bit of a split, and I think basically you're between the two very reasonably right answers. So you've seen someone with huge ventricles and you're thinking like, have they got raised intracranial pressure? That would be something you'd want to rule out. You obviously wouldn't want to do that if you wouldn't want to do a lumbar puncture on someone with raised ICP, because they might like cone. So it kind of goes off the CT scan. For those that put D, can you give me like the other symptoms that you might kind of push you towards your diagnosis? And I think it's slightly in the clinical history. So yeah, it's this kind of wet, wobbly and weird thing. So normal pressure hydrocephalus. So normal pressure hydrocephalus, you'll see it on Jerry's if you've not done it yet. And also it depends where you are, to be fair. Like I just had quite a few on my ward, but typically like over 80s patient, they get, it's a slightly convoluted mechanism, but basically they get a change in the equilibrium of like their production and removal of CSF from the system. And so they end up with this kind of progressive swelling of their ventricles, which then presses on the corticospinal fibers, and it just affects how they move. It affects their bladder function, that kind of thing. So they end up a bit confused, wobbly, and wet as well. And it's one of these reversible causes, potentially reversible causes of dementia, is what it's known as. So, and then how is the gait normally described? So it's not really an ataxic gait. So it's a wide base gait, yep. There's like one key word, which like once you know it, you won't forget it. So I don't think it's the waddling one. What's the waddling one? I feel like the waddling one is more like an antalgic gait where it's painful, but it could look like, to be fair, it could look waddling if they've got that. But basically it's what's called this like magnetic gait. So it's this slow, their feet are almost stuck to the floor. It can look like Parkinson's, and that's like a common thing that they can be kind of misdirected as until they do the scan and realize. But if you see someone who's got like, they're describing their feet are stuck to, almost stuck to the floor, this kind of magnetic gait, it's more likely to be normal pressure hydrocephalus. Cool. And yeah, that's that. So what is the finding apart from the enlarged ventricles, like on this scan? Like what could this, there's a finding on the scan which relates to like the treatment of this condition. And I don't mind how you describe it. So this is like a CT scan. So as I was kind of actually told today, so it's either hypo or hyperdense, whereas MRI, it's like intensity that you talk about. So do you notice anything odd about the scan? Yeah, so there's a white structure in the ventricle, so I hope everyone can see it. And so one option is calcium, which like if you want to look for any calcification in the brain, like CT is the one to do it. But it's very, if you look at it, it's very, very like round, almost like too perfect, but like it's a fair enough differential. And I think you're more likely to get like the calcification like in the parenchyma somewhere, or it would be kind of patchy if it was in the ventricles. But yeah, Anoja's kind of on the money, so it's a shunt. So if you've got someone with this kind of ill draining CSF, they'll put in a shunt. So this is kind of showing it better. And it will be a ventriculoperitoneal shunt, so it will go kind of all the way to the abdomen. There's a couple of options, but generally like that's one of them, and that's the kind of management for it. Cool. Okay, so I've got 2 more psych ones, and then I've got some super random picture quizzes. So a patient presents to you with the following fundoscopy examination. Which of the following best describes a constellation of psychiatric symptoms they may get in relation to their condition? So if anyone can tell me like what the fundoscopy shows, that would be fab. I have covered it before, so if anyone went to that, I have covered it. And then just give these answers a go in your own time. And then after we've done those 2, we'll then go for the money of like what this is as a phenomena. This is like niche psychiatry, so like if you don't know this now, it's okay. It's completely fine. It's not niche, but like it's you know, it's not your really bread and butter kind of stuff. But it is something that they could describe to you. So we got one for D. Anyone else want to give it a whirl? I mean, they're all deliberately like variations on a theme. So yeah, we've got D again. And so Jess, I know you were at my opthal teaching. What is this, Jess? Or someone else? I know some people are definitely at the opthal teaching. Yeah, no pressure. I mean, whenever you're looking at opthal, just think, is it the disc? No, the disc looks all right. What structure is chilling here? The macula. So yeah, there's drusen in the macula. So what would be like the likely condition that would cause drusen in the macula? Yeah, so age-related macular degeneration on the money. What is the most likely type that this person's got? Wet or dry? Yeah, so it's dry. So if you're not sure, dry is like 90% of cases. It happens very insidiously. They get drusen. There's no like new vessel formation, whereas wet is the 10% new vessel formation, and you can do like the VEGF injections. There's really not much to macular degeneration because we can't really do much about it. So yeah, this person will have like some visual impairment, central vision, and as like two people have said, it's we're aiming for D, so it's called Charles-Bonnet syndrome. And so this is where people with visual impairment will get like a persistent or recurrent hallucinations. So probably with visual impairment, it's going to be like more likely, I think, visual hallucination rather than like so what's the difference between simple and complex hallucinations? So I think it's more that they get, I'll have a look at a definition, but probably like a simple hallucination might be like that they see just one kind of shape or object that's not particularly complicated in their vision. And it might go as well for auditory. For auditory, it might be simple sounds or like a very similar phrases or like thing that comes up, whereas a complex might be more of like when they hear a person talking to them and it's a running commentary and it's all these other elements and it varies depending on their stress on the day, that kind of thing. And the same with like visual, it might be like that they see, for these people, they can sometimes see like very disturbing scenes or very quite graphic images, quite similar to like OCD people also get similar things. So it might just be that. I don't know if there's like a precise thing kind of cut off. I was just trying to kind of spice it up a bit. So yeah, so they can be persistent or recurrent. There's quite a like low remission rate. So it's about 25% will get better by 9 years, but the rest don't. I don't, in fairness, know how you treat it. But I don't think you're really expected to know that. But yeah, those are kind of the take homes really. If someone's got like a significant visual impairment, they can get that. Okay. So you're then seeing two people that have started psychiatric medication. So let's just take this gentleman here first. So this gentleman describes and you see this constant restlessness from him. He's got these kind of chorioathetoid movements. He's got these writhing movements in his limbs. He's also got these kind of, keeps pursing his lips, keeps kind of grimacing, where he's like not able to control himself. Does anyone know what that's called as a side effect of the drugs? So yeah, that's called tardive dyskinesia. Fantastic. Does anyone know like the drug for tardive dyskinesia? So the thing we worry about is like if you just leave them on it, it can just become quite permanent. So they look to treat it. It begins with T, if that helps anyone. And I feel like if you've forgotten the drug, it starts with T. And it's also one of those ones like I feel like you could easily kind of slightly misspell or mix up with something else. All right, we'll come to it. We'll come to it. Then you've got this gentleman on the right. So he's got his head is turned to the left and he can't move it. And he's very, very stiff. And he's got some, yeah, he basically can't move his head. It's very painful for him. His muscles are all spasmed. Does anyone know what we'd call that? Yeah, acute dystonia. Fantastic. And yeah, the movement of the head to the side is torticollis. So well done, guys. Does anyone know what the kind of acute dystonia is called, where like they get their eyes get stuck looking up, or maybe like looking slightly to the side, but like the classic is like their eyes, they just can't keep, they're stuck looking up. Yeah, fantastic. You guys are on it. So yeah, ocular gyrate crisis. So tetrabenazine is the one that we use for tardive dyskinesia, so T tardive, and then procyclidine or benztropine are used for acute dystonia to kind of relieve it. And acute dystonias can happen with like very classic antipsychotics that are used, haloperidol, risperidone, olanzapine, that kind of thing. They can also occur with some of the like really old school antiepileptics like carbamazepine and stuff, but I think they'll give you like a much more classic history with like one of the typical or atypical antipsychotics. Cool. Does anyone have any like questions on psychiatry? Because I'm now just going to move on to a picture quiz which has no relation to psychiatry. So if anyone has like any burning questions before we like go to a picture quiz. Otherwise, like we can message after the session. So as I've not heard anything just yet, I will crack on. So I did some opthal, so we'll do some opthal. So does anyone know what any of these are called? So yep, hypopian's in the middle. So that's, yeah, pus in the anterior chamber of the eye. And then, yep, the first one is hyphema, so that's blood in the anterior chamber of the eye. And then, yeah, chalazion on the right, so fantastic. So blood in the eye, you're thinking trauma or like some sort of spontaneous bleed. Hypopian, sorry, getting them mixed up. Hypopian, you're thinking like anterior uveitis, bacterial infection, that kind of thing. And then chalazion is just infection again, but is much more like cosmetic, unless it's like, obviously it's really large and unsightly and everything, but it's much less like worrying from like a clinical point of view. Cool. All right, so some peds. So 2 abdominal conditions, left and the right. So you've got this with some very nicely drawn arrows. And then we've also got a baby that will not stop throwing up. These aren't the same condition, they're just slightly related. And points if you can say like what the sign is on the X-ray. So pyloric stenosis is the second one, so that's the classic like milky vomit, won't stop vomiting, nothing will go down. And then, yeah, so double bubble is on this X-ray, and which condition has double bubble? It's kind of like the sister to pyloric stenosis with the green vomit. bilious vomit, atresia. So if you had to pick one, which bit? It's probably like the one you're thinking of, and then you've like second guess, which is what I do. So yeah, it's duodenal, yeah. Because like anything lower, it would kind of, you might get like more kind of feculent matter, I guess, like if it's been more digested. So yeah, this is double bubble, duodenal atresia, it will be bilious vomiting, pyloric stenosis. It won't be like getting to the duodenum, so it's going to be very milky vomit. Cool. We now have a rash. And you may think this is a bit harsh, but like they do often give questions where they just give you the bit of the rash. So I found looking at loads of pictures of things all the time was really useful. Navitha's got it. So this is pityriasis rosacea. It's one of the two. I can never say it. I just pick it on an answer. So you can see the herald patch there. It's not the best one. I could have given you the kind of characteristic Christmas tree rash on the back, but like, yeah, this is pityriasis, and you just reassure them and just like it'll clear up. Okay, so you see a young man who has a very itchy rash that's a bit vesicular looking on his elbows, his knees, and kind of his upper arms. Yeah, Lubna's straight in. So dermatitis herpetiformis, like what condition might the patient have? To kind of add to that. Yeah, so celiac, cool. So we do some IgA and we do some TTG antibodies. Nice. Okay, so we're kind of moving into Kaiser territory of I think that's the only clue I'm going to give you of like what she's been teaching this year. So what do people think this might be? Yep, so this is Carposy Sarcoma. So if you look here, this is why you've always got to look at the mouth with people that you suspect that have HIV, because they can literally just be in the oral mucosa, and like there are pictures online where you can lift up and see it in the gum as well. And then this is so there's different types of Carposy. So it's not, you don't need to do this for exams, but it's not just like, oh, they'll have HIV. There's like I think it's called like an endemic form, which is like in the Mediterranean where people have it, and it's usually on the feet, like here, and there's a slight genetic predisposition, and then other immunodeficiency states. So it's not purely HIV, but for the exams and for real life, you'd always check them for HIV. Cool. So 2 other skin signs. So I'd like the skin signs, and then I would like the overarching diagnosis. So yeah, cafe au lait. Nice. And then I'll give you the body part that's like on the back. So yeah, that's shagreen patch. So neurofibromatosis could be the right answer if they just had the cafe au lait. If they had both, what would we be thinking? Tuberous sclerosis. So if you've got someone who's got shagreen patches, subungual fibromas, so like in the nail bed, cafe au lait, autism, or like some sort of autistic spectrum, epilepsy, maybe a low IQ, then you're thinking like tuberous sclerosis. Neurofibromatosis type 1, you're thinking of like cafe au lait, increased risk of malignancy, that kind of thing. I think it would just come up in like a purely pediatric thing. And I think the distinguishers would be like that someone with neurofibromatosis would probably have like a normal IQ and normal behavior, whereas someone with tuberous sclerosis might not. Cool, but yeah, they're always slightly compared. And these are autosomal dominant. So yeah, so tuberous sclerosis, autosomal dominant, because they do get these kind of tumors as well. Cool. All right. So this is kind of one where like it could be, I think when they show it on the legs, there's kind of 2 big diagnoses that are compared. for this, if you're looking at it, you can see that they've got a surgical scar that's well healed, and they've got this rash. And it's the sort of thing where, like, once you see it, you'll never, like, unsee it. And you'd be surprised, actually, how many times you do see it. I think I've seen it, like, a couple of times since starting. Yeah, and, like, literally the name, like, what is the name? It probably does mean something actually quite sensible, but, yeah, erythema abigni. So this is someone who's, like, this is siderosis, like, from heat. So this person's probably got a hot water bottle on their abdomen, probably because of chronic abdominal pain, and you get this these deposits basically in the skin of like siderin. And so when it's on the legs, it can look a bit like libido reticularis, and you can kind of think like, is it like, yeah, antiphospholipid or something? But if you see it somewhere quite unusual, that's what you're kind of thinking is erythema abigni. But again, like a bit of a stretch question. So you see someone in ED, you see this rash, do you go and put some gloves on? And this is like a 5th year condition. So yeah, maculopapular rash on hands and feet, and it's so like palms and soles, because a lot of rashes like don't affect the palms. So if you see someone with a palmar rash, you're thinking like secondary syphilis and like a couple of other things. But for 5th year secondary syphilis, when does secondary syphilis kick off? How long after initial infection? Kind of a slight estimate of like when would you expect them to have been infected if they present like that? Yeah, so it's like 1 to 3 months. So yeah, 4 to 6 weeks is completely a shout. So and you'll ask them about their kind of acute phase primary syphilis, like the chancre and like feeling systemically unwell. Cool. All right, whoever is on urology, you do a cystoscopy and you see this, and I always think it looks a bit like coral. What are we thinking? And anyone can answer this, to be fair. I'm not just picking on like the people in urology, but like this could be a kind of classic photo they show you. You do a cystoscopy on a 65-year-old woman. So yeah, you don't know. I mean, you don't know if it's superficial. It could be going into the wall, to be fair. But like, yeah, it's bladder cancer. The most common of which would be transitional cell. What's the biggest risk factor for transitional cell? And don't worry, it's not like a genetic syndrome. Yeah, smoking. Cool. And then what's the other subtype of bladder cancer that's kind of the second most common, the only other one you really need to know? Yeah, the only one you need to know. Yeah, squamous. What the main risk factors for squamous? Maybe not in like Hampstead or Euston, but yeah, schistosomiasis good. So like Lake Malawi, those snails, yeah, cool, fantastic. Okay. We're seeing all the beautiful things today, honestly. What are we thinking? I mean, I'm pretty sure everyone knows this photo because it's like the best photo for it. But you never know what the med school put up. So what are these 2 conditions? And then don't worry, we're like literally the last hurdle. So if everyone's like a bit frazzled from this slightly random eclectic mix. So yeah, bullous pemphigoid on the left. So you could think toxic epidermal necrolysis for the right one, like that's fully a shout, because you know it's their skin's peeling, it's coming off most of their body. So that is a shout, like Stephen Johnson. But if we're saying like pemphigoid is that one, what's this one? Yeah, so pemphigus. Which one would you rather have? Sorry, that's like a really bad question, but like which one is like you're gonna get a lot sicker? So I'm pretty sure it's pemphigus where you get a lot sicker. But I feel like I asked that question and I wasn't committed to knowing the answer, but I'm pretty sure it's pemphigus. Oh, as in you'd rather have that one. All right, yeah, cool. Okay. So yeah, pemphigus, they'll be a lot sicker than pemphigoid. You guys will probably know the antibodies. I've legit forgotten them. But pemphigus ends with an S, so it's superficial. The blisters slough off, whereas pemphigoid with a D, they're deep. They're therefore like very tense blisters. And yeah, like go on PassMed for the antibodies because like I've forgotten. You see this patient in A&E. Sorry, my cat's just woken up. Do they have bilateral cellulitis? Or do they possibly have something else? Yeah, so chronic venous insufficiency is the reason for this. Do you know like what the name of this rash is? I guess is it a rash, the skin change? Yeah, so venous eczema is like the it's a quite colloquial term for it, but like it's a shout and it's more just like that dry skin. But the specific change in the color, and it can look quite dark on certain patients, is like lipodermatosclerosis. So it's this appearance, and they can get like thinning of and atrophy of the muscles around and things like that. So yeah, bilateral cellulitis like not really a thing unless like they impressively got entry points to both legs of bacteria. I guess never say never, but very, very unlikely. Cool. Okay. And like we're literally down to the final two, so don't worry. And they are like variations on a theme. So we've got this chest X-ray, and then we've got this picture of a girl. So yeah, it's Turner's on the right. And so if we think about what cardiac abnormality Turner's children get, that can give you, to be fair, it's something like you just might not have heard of it because I think I only learned it like right at the end. But yeah, so it's coarctation. And so if you've got aortic coarctation, you kind of get like this dilation of all these collaterals, and some of the collaterals are like the intercostal vessels. And so you can end up with this appearance of like rib notching if it's been left for ages. So if they mention rib notching, it's aortic coarctation. And generally, like for girls, if a girl has aortic coarctation, you want to test for Turner's because it's much more common in males. And so really like one of the most common reason that a female will have coarctation is because of Turner's. Cool. So we see a baby who then grows up, and the baby is born with like, again, a slightly webbed neck, but it's a boy. What is and they have these kind of faces, so quite like triangular, quite wide spaced eyes. And they have a cardiac abnormality. What is the syndrome, and what is the cardiac abnormality that they'll have? So yeah, this is Newlands syndrome. Good. And what's like the most common cardiac defect in Newlands? Final question of the night. It's all right, don't worry. So it's like a valve. One of the valves is a bit funny. It's like a 25% chance of getting it right. Yeah, Navitha's got it. So it's pulmonary stenosis. So if you've got a child with pulmonary stenosis and a web neck, you're going more towards Newlands. So yeah, fantastic. Cool. Okay, I hope that was useful. There was a bit of like a mix of a bit of a whirlwind of like the influence of me being a Queen Square and other things. Please feel free to fill out the feedback form. I think Divya and James are teaching next week, so that'll be really, really good. And otherwise, like, have a really nice Easter break, everyone, like for the short kind of weekend that we have.